Hello, hi. Have a good evening, have a good night, have a good day or good morning, wherever you are. Depends on your time zone. My name is Serhat Bor from Izmir, Turkey, and this is the program we call it Speed Date with Experts in 60 Minutes. This is the monthly webinar series organized by European Society of Neurogastroenterology and Motility, and Turkish Society of Gastroenterology. This is the 6 programs, friends, and thanks for joining us for each program. And the first 3, we have, the first program was about the IBS on IBD. The second one was about the eosinophilic esophagitis. Third one was actually regarding the reflux disease. And the fourth one, we discuss a difficult situation, abdominal bloating and distension as a nightmare. Fifth one was again full with experts about achalasia. Now we have already established the future programs. What are they? 3rd of April, please join us with bile acid diarrhea with Barbaro, Giovanni Barbara, and Marasco from Italian team. 2nd of May, microbiota and functional bowel disorders, Tarkan Karakan, Francisco Guarner, and Dan Dumitriescu. And the 5th of June, postprandial distress syndrome and functional dyspepsia from Leuven team, Scholl, Yantak, and Brothers. And how about today? As you know, this is a program exactly we finish on 60 minutes. We have 2 distinguished speakers. Mark Fox kindly accept to talk about the basic and translation science study, as well as he is going to present an interesting case. Jutta Keller is going to talk about a paper regarding the clinical science. Let's start with Mark Fox first. Mark is a professor in gastroenterology in University Zürich, and he's going to talk about a somehow old but very interesting paper regarding the determinants of fecal continence in healthy continent subjects. Mark, thanks for joining us.
Thank you very much for inviting me to speak, Serhat. Are my slides showing? I hope so. If so, we'll start straight away.
Perfect.
Thank you. So what we want to do today is to talk about continence and defecation. And I'm going to start with the first part of this equation. Now, clearly, all of you will recognize that continence requires 2 things. One is a functional rectum, providing a reservoir for stool and gas. And secondly, also an organ that detects distension. The rectum knows whether it's full or not. This is very important because all we have to do is hold on. But do we hold on? It makes a difference if it's solid, liquid, or gas. Already there is a level of complexity. The anal sphincter is involved, of course, in holding things back, but it is also essential to tell you what is in the rectum. The rectum only detects its stretch. The anal sphincter is a highly tactile organ, and it will tell you whether it's liquid, you need to run to the toilet, solid, you can hold on, or gas, well, if you're alone at home, you can just let it go. Although this is clear to all of us, there's a huge imbalance in the studies. You see here, there's thousands of studies about anal manometry, and this slide is already a couple of years out of date, but only very few about rectal function. And what we can see here is that we need to try and understand everything that's going on. And the purpose of this study, which is a little less than current, but is still relevant because these issues are still not fully understood by clinicians. What we want to do here is we wanted to understand what were the determinants of continence function in healthy continent subjects. If you don't know this, then you can't interpret the studies properly in patients. So we did a comprehensive analysis using various modalities, very importantly, including a stool substitute retention test, which is quite an exciting thing, which I shall describe you. So we had the aim to determine the factors that correlate with anal rectal filling sensation and fecal continence. We looked at 42 continent healthy subjects. They were all either male, about half, or nulliparous females, and they had not had any children. It was a prospective study that was performed, and patients with any history of GI disease were excluded. Now, the measurements that we did were of rectal capacity, rectal compliance, rectal sensitivity using a barostat. I will describe this later. We assessed anal sphincter function using manometry. This was in the days before high-resolution manometry. And we literally filled the rectum with stool substitute. Why did we do this? Well, because if you're going to assess continence, then you need to test continence. You need an independent measurement of the patient's or the proband's ability to retain stool. And this is what this archaic but actually rather excellent test demonstrates. The anorectal manometry measured resting pressure using a pull-through technique. You got 4 measurements. We took the average. We then used a longitudinal catheter to get squeeze pressure and squeeze duration, although I won't talk about that today. And we can see you can measure squeeze pressure in a robust fashion. Just for the record, validation studies show very little difference between the assessment of these measurements, these pressures, using conventional or high-resolution manometry. We then also used a barostat pump and a barostat bag. A barostat bag is an infinitely compliant, which means it's plastic. It does not stretch, but it is oversized. So what happens, you put in this very soft plastic bag into the rectum. In this case, it's got to be bigger than the rectum. So it's 700 milliliters in size. And you use then a pump to fill it. In other words, the bag itself, unlike an elastic balloon, does not provide any resistance, which means it fits into the rectum, and when you fill the bag, you can get a volume pressure relationship. That means as you increase volume, the pressure in the bag also increases, and you can see how these two things relate to each other. This is the kind of data that you get in a pressure volume curve, volume on the y-axis, pressure on the x-axis. You can see that after you exceed intra-abdominal pressure, MDP, minimum distending pressure, that simply recognizes the fact that the abdomen has got more than a 0 pressure. There's some pressure acting on it. Obese people, this will be higher than thin people. But then once you overcome that initial resistance, you get a rapid early expansion, and this is what is referred to in the literature as compliance. After you get beyond about 20 millimeters of mercury, this increase in volume slows down. And this is because you've now exhausted rectal relaxation. You're now literally like pressing against the serosa, and this takes more pressure. And it's at this point that you start being able to understand that rectal function is not quite so simple. It's not an infinitely expandable object, obviously. And at a certain point, you can also define rectal capacity. Now, this isn't done very frequently, but it's extremely valuable, as I shall show you. It's valuable, not least because it also correlates to sensation. We understand, we know from experience that first sensation happens at this first inflection point. As soon as the rectum really starts to increase in size, you're generally aware of this. Urgency happens when you pass this second inflection point where it stops expanding rapidly, starts expanding more slowly, and pain is actually sensed at about 35, 40 millimeters of mercury in health, which is getting close to our assessment of capacity. Here you see our stool substitute retention test. This was potato puree, instant potato puree, which were mixed to a viscous fluid, a bit like molasses. The patient was seated on a commode, and we literally used a peristatic pump to get up to 1.5 liters of this stuff into people's backsides. An extraordinary thing to do. You should see my collection of photos, because we recorded all of this with a camera, And we also recorded the patient's sensations. And when the patient started losing stool, we noted that moment. The patients had, of course, been instructed to hold on for as long as possible without leaking. And we often found that this actually provided quite a stable measurement. So we continued even after they started to leak, but they couldn't hold any more. You gave a bit more in, they lost a bit more. And this was a very stable measurement, much more stable than you might imagine. And what was very striking was that the most powerful correlation was between rectal capacity at 40 millimeters of mercury and the amount of stool that was retained. So people with a large rectum, shall we say 500 milliliters, they could retain almost the entire liter and a half. People with a small rectum, say 200 mils, could only retain about 400 milliliters of stocky of this stool substitute. So you can, it's striking. You suddenly realize that there is a maximum reservoir volume, and if a reservoir is overfull, then we all recognize it will overflow, it will leak. We also were able to confirm our hypothesis that people didn't respond to particular volumes, they responded to being how full they were. So if you had a patient with a large compared to a patient with a small rectum, the compliance appeared to be higher in the large rectum than the small rectum. But if you think about it, that's inevitable, that's physics. But what's much more striking is the volume that it took to stimulate these people was very similar if expressed by a percentage. So you started getting first perception around 20% full, you started feeling urgency around 60 to 70% full, and pain really only happened, or a very strong sense of urgency, only when you were very nearly at capacity. So we then had all of these measurements, and we did a multiple regression analysis to see what was important. Remember, we were looking at sensation as well as continence. And resting pressure was, in fact, by far the most important measurement when it came to first awareness. So rectal capacity was significant. You can see the level of significance here on the y-axis. Anything above 2 is clinically significant. So P is less than 0.01. But it was a little bit significant, but resting pressure was extremely significant. This is a novel finding, but it makes sense. Why do you have a resting pressure? It's to protect your continence function all the time. If your internal sphincter is under stress by rectal filling, you will know about it. This is what triggers resting. This is what triggers first awareness. Urgency, on the other hand, was a complex metric. All of these measurements were associated with urgency. This is not surprising either. Both the anal sphincter and rectal capacity are involved in urgency. So when you realize that your continence is threatened, either because it's just really full or because your sphincter is perhaps not that strong, you will get the urge to go to the toilet. Incontinence was really associated very strongly with rectal capacity, but also with squeeze pressure. Because after all, when you really need to go, it's the strength of your squeeze that will get you to the toilet. So this basic translational research really gives a very clear impression of the relative importance of rectal reservoir function and anal resting and squeeze pressure in how sensation and continence is determined. It's very important to realize that compliance was not associated with anything independently. It was associated with all of these things, but it was always a less strong measurement than capacity. It was also very interesting that age and sex was not associated with these functions at all in terms of first incontinence. Basically, if you do lose sphincter pressure as you get older, your sensation increases and you compensate. And that's why even elderly people and even people with a weak sphincter can remain continent. It's because you compensate, you get early warning and you run to the toilet. So in summary, these tests show, using a multimodal approach, that anal sphincter function is important but not sufficient for continence. Rectal capacity and sensitivity are integral to this very important physiological process. And the measurements that we obtained explained not only symptoms, but also the limits of continence. I should mention also that stool consistency is also very important. Adil Baruka has shown that diarrhea is in fact immensely important to incontinence. The odds ratio is 50, which is extraordinary, whereas obstetric injury, the odds ratio is only about 4. So it's always essential to regulate stool consistency when you're dealing with our patients. If you apply this technology in clinical practice, we got 100% yield, if you like, when we looked at patients who had normal sphincter function but were still complaining of incontinence. Every one of them had disturbances of either rectal capacity or rectal sensation. And these days, you can do barostat studies very rapidly using an abbreviated technique that we've developed. So in conclusion, the causes of impaired continence function are many: sphincter function, reservoir function, abnormal sensation. It's only when they come together that you're likely to actually experience this. And don't forget, diarrhea is an important cause of incontinence also. Thank you very much for your attention.
Thank you, Mark, for the lovely presentation. Please ask your questions from the question and answer part of your screen on behind. We are waiting for your questions. Mark, in your study, the number of deliveries, vaginal deliveries, is always a variable. What in many countries, non-Western countries, females have, more than 3, 4, 5 vaginal deliveries.
Yes.
What is the correlation, you think? And do you agree that there should be 3 types of normals, male, non-delivery female, and, females with many deliveries, whatever? Is there any correlation study, or should we?
Yeah, well, we have so Henrietta Heinrich and I have collected more than 600 individual cases as opposed to healthy controls, and what we've seen is a very strong correlation with all the factors that we have shown here. So yes, when you have children, on average, sphincter function will be reduced. Exactly how it's reduced is actually very variable. And what's very striking is we see some women who have, especially women who have very weak function, but they're continent most of the time, unless the stool is weak, unless the stool is loose. And all of these continent people who respond well, they have rectal hypersensitivity. Why do they have it? Operant learning. If they weren't sensitive, they would be incontinent much more frequently. And we see, by phenotyping this large group, we see that the people with the most severe incontinence have combined sphincter weakness and rectal hyposensitivity. So if you neither feel the stool in your rectum, especially at low volumes, so it's the people who have got poor resting pressure that are affected here most particularly. If you have that, and then also a weak sphincter, then you're lost. You don't feel it coming, and it's gone before you know.
There's one question regarding with your topic, if you allow me. Shenjan from Turkey, she's asking whether the stool incontinence is there any patient management difference according to the sensations, first sensation or urgency or maximum tolerance, the stages? Does it change your patient management protocol?
Certainly. So in people who have got a small rectum, possibly post-operative, sometimes from as a primary small rectum, so they can't tolerate large volumes of stool. And in this group, if you're choosing something for stool regulation, then you should choose something that doesn't increase stool volume. So, for example, if you're trying to thicken the stool, flax seeds, which are very, very commonly used, or linseeds, they're not appropriate because they increase the volume quite dramatically of the stool. Whereas if you use pectin or gelatin, which are available as supplements in most sort of like apotheken, pharmacy. Thank you. Then that doesn't increase your stool volume and still thickens the stool. It subtle things like this you can achieve so much using very simple preparations, natural preparations, often low doses of Imodium which increase the tone of your anal sphincter, and of course may also in slightly larger doses also slow down your colon. It is extraordinary what can be achieved, but it's also extraordinary how poorly these people are treated before they're referred. So, but understanding the underlying physiology definitely guides effective management, and that's been shown in multiple studies also.
But can you tell during...
If you have a question, go ahead, please.
Yeah, please. During your stool or the rectal filling test, can you tell how much of the substance will go up into the sigmoid colon? Will it won't stay?
No, so we did do an imaging study, only in a very small number, using MRI, because Zürich is well kitted out for that kind of thing, and we found that that when we use the actual liquid, because in the olden days, a famous guy called Nick Reed, who is my hero, he infused water into the colon, and that got all the way around to the cecum, and 1,500 milliliters. Most people took it, whereas with my viscous preparation, it generally didn't get beyond the flexure, the left flexure. So that it filled the left side of the colon and sometimes just the sigmoid. It was a somewhat variable, but the volume that you could retain was always larger than the rectum volume. And so it's reasonable to say that the rectum is an important but not the only part of the reservoir.
Yeah, interesting.
There is a comment, one of my fellow used to work with, but we have a very limited time, Mark. Please, short answer. Yep. I use it, and one of my fellow, Elba Suni, he reminded that we use for the patient with rectal hypersensitivity and fecal incontinence, we give them small suppositories, glycerin or similar stuff. What do you think about that?
Yes, absolutely. So Mark Scott has shown in a very large group of people that emptying difficulties, so defecation problems, are often reported at the same time as stool incontinence. And it's very clear that whether you use suppositories or even transanal irrigation, that if you wash your patient out, then they're clean and they won't be incontinent. So if that seems appropriate, it's a very good approach.
They make the rectum, maybe it's for the megarectum, a little bit smaller size.
Well, they probably stimulate a more complete evacuation.
Okay, thank you, Mark. We'll come back to you for the case discussion. Now we are with Jutta Keller, who is working in Israeli hospital in Hamburg, Germany, and she's going to present a very recent paper published in Gastroenterology, comparison of anerectal manometry, rectal balloon expulsion test, and defecography for diagnosis of defecatory disorders. Jutta, thanks for joining us.
Thank you, Serhat. You can see my slides, can you?
Yes, lovely,
yeah,
no problem.
Okay, so we will switch from fecal incontinence or mechanisms which prevent incontinence to patients with chronic constipations. Of these, around about 45% have either only a defecatory problem, delayed rectal defecation, or rectal defecation problems together with slow transit constipation. This has been shown in a recent systematic review from Michael Camillieri's group. And these defecatory disorders, they are either functional, caused by dyssinergic defecation, or anatomical and structural. International guidelines advocate that 2 tests should be performed to establish a diagnosis of disordered defecation. 1 test of anorectal function, that would be high-resolution anorectal manometry in modern times, and 1 of rectal evacuation, which is either the balloon expulsion test or defecography. For high-resolution manometry, there are different systems and different catheters which can be applied. All of them have a balloon with a pressure sensor inside, and several closely spaced pressure sensors which are in the anal canal to measure the pressure. And investigators follow a strict protocol, the protocol of the International Anorectal Physiology Working Group, published as the London classification, where we have a stabilization period, then the resting pressure is measured over 60 seconds. This is followed by a sequence of squeezes, cuffing, and then the patients are encouraged to simulate defecation, to push several times. Again, after this, rectal sensory testings are performed. Patients are asked whether they sense or not a certain volume which is filled into this balloon, and when they have urge and pain. And at the end of this anorectal manometry protocol, the rectoanal inhibitory reflex is tested. This is how these investigations look like. You can see the pressure within the rectum up here and the pressure in the anal canal down there. And pressures are color-coded with low pressures in blue and green and higher pressures in yellow, orange, and red. And you can see that during resting, there is a low pressure in the rectum and a constant low pressure in the sphincter. When patients squeeze voluntarily, the pressure in the sphincter increases considerably, whereas the pressure in the rectum remains low. When they push and do this as physiologically intended, the pressure in the rectum increases due to the contraction of the abdominal wall, and the pressure in the sphincter decreases so that the stool inside can be pushed out. The anorectal inhibitory reflex is tested by balloon distension. When the rectum is distended, this will cause a refractory relaxation, a decrease in pressure caused by relaxation of the sphincter internus mainly. The balloon expulsion test for this subjects is frequently performed immediately after the anorectal manometry. Subjects are asked to lie down in the left lateral position for insertion of a flexible catheter with a balloon at the tip into the rectum. The balloon is filled with 50 milliliters of water, and then the subject is transferred to a sitting position, ideally on a toilet in private conditions behind a curtain, which is not always possible in a lab. And they are asked to evacuate the balloon and to record the time they need for balloon evacuation. This should be possible within 1 to 2 minutes. Defecography will give you information on structural defects. As you can see here in a woman, the rectum is filled usually with ultrasound gel, to show the volume, which is firstly normal. When the subject is asked to bear down, you can see a rectocele forming, not too large, but it's visible. And in the later stages of the defecatory process, the rectum or the anal canal is obstructed by interception of anal mucosa. And there are also smaller descents of the bladder and of the vagina in this patient. But you can also gain functional information from defecography. So you can see here during resting, there is a normal anorectal angle in this patient. During squeezing, the angle is reduced, which is physiological, so that the content cannot get out. It will push down here, but not onto the anal sphincter. During evacuation, the opposite happens. The angle becomes larger so that the content of the rectum can go down here. And during paradoxal contraction, the anal sphincter does not, this angle does not open up, but it remains quite small, and the sphincter contracts. This looks like this in the simultaneously or in the high resolution manometry. You can see that this subject does push. There is an increase in the, oops, that was too quick. There's an increase in intrarectal pressure, but also a marked increase in the pressure within the anal canal, so that the pressure here cannot be overcome. And there are other kinds of dyssinergic defecation where there is a decreased propulsive force, or whether there is a decreased propulsive force together with a paradoxical contraction. Although these different methodologies have been proposed to be performed in patients with defecatory disorders, there were until now only some small studies actually investigating the utility of the individual techniques for diagnosing defecatory disorders. And this was now investigated in a large study from my Baruka's group, also from the Mayo Clinic. The first author is John Blackett. And the aims of these authors were to evaluate diagnostic utility for identifying a defecatory disorder regarding to high resolution manometry, balloon expulsion test, and defecography, and to clarify recommendations for anorectal testing in patients with suspected defecatory disorders. They performed a retrospective cohort study, and they identified all patients with constipation investigated in 2018 in their institution, and they recruited healthy subjects who had participated in previous studies, so they took their data. High-resolution anorectal manometry was performed in all subjects, and the authors analyzed resting anal pressure, the squeeze pressure, and the increase in pressure during squeezing in comparison to resting pressure. Rectal sensory volume thresholds for first sensation, urge, and discomfort. And during stimulated defecation, they measured residual anal pressure, percentage of anal relaxation, rectal pressure increase above baseline, and recto-anal pressure gradient. This parameter is important because I will come back to it. It is rectal minus anal pressure, which means that low values are equivalent to low propulsive force and or high resistance in the anal canal. How this recto-anal pressure is actually calculated is system dependent. The authors use the Medtronic system, and this uses highest pressures at each time point for calculation. The balloon expulsion test was performed immediately afterwards in the manner as I've shown before, and a balloon expulsion time of more than 60 seconds was defined as abnormal. And for analysis of MR or barium defecography in constipated patients, these authors mainly evaluate rectal evacuation using a semi-automated method, which allowed them to determine rectal area and rectal volume, both before and after defecation, and to calculate the percentage of evacuation, which below 25% was defined as reduced. The authors included 658 participants, really a large number of subjects. Among these, 184 healthy volunteers and 474 patients with constipation. Around about 80% of these had functional constipation, around about 20% IBS-C. As I said before, high-resolution manometry and balloon expulsion test was performed in all subjects, but defecographic data were evaluated from constipated patients only, and defecography was performed in 1/3 of the patients with constipation. For the data they analyzed, first of all, they compared the data obtained in healthy volunteers with the constipated patients. And constipated patients, in this group, there was a higher proportion of females, 89% versus 73%. Constipated patients were older, about 15 years older. Women had a higher likelihood of having had pregnancies higher number of births and a higher likelihood of hysterectomies. An abnormal balloon expulsion test was observed in more than 30% of patients with constipation and around about 10% of healthy volunteers. Reduced rectoanal gradient, increased urgency thresholds, and reduced anal squeeze increments were also more frequently observed in constipated patients in green compared with the healthy volunteers in blue. Men and women had different, for instance, resting anal pressure, but differences weren't that large for other parameters. And there were differences between women who were younger than 50 years and those who were older than 50 years, for instance, also with regard to resting anal pressure. The authors also try to find out which of the HRM parameters is actually the most useful one for predicting a pathological balloon expulsion test. And here you can see sensitivities of the variable anorectal manometry parameters, which ranges from around about 10% to 36%. Specificity is higher, it's between 80 and 95%. The positive predictive value is between 40 and 53%, and the negative predictive value for all parameters ranges between 69 and 75 roundabout%. The one parameter which was actually best was this reduced rectoanal gradients, which I've alluded to before. And multivariable logistic regression analysis showed that a reduced rectoanal gradient, reduced squeeze increment, and increased threshold for urge sensation each independently predicted prolonged balloon expulsion test in constipated patients. From these findings, because of these findings, the authors recommend that high-resolution anorectal manometry variables must be interpreted relative to normal values measured with the same technique in corresponding sex and age groups, and that reduced squeeze and sensation should be considered as supplementary criteria for a defecatory disorder. The authors also compared the number of pathological or abnormal manometry parameters with the proportion of subjects who actually had prolonged balloon expulsion testing. And they could show that with an increasing number of pathological manometry criteria, patients were more likely to have an abnormal balloon expulsion test. However, there were also many subjects with only one, with a normal manometry or with only one pathological criterion who had a pathological balloon expulsion test. It was 20% of the constipated patients who fulfilled these criteria. Furthermore, the authors, they did quite a lot of comparisons and generated really a lot of data. They also compared the combination of balloon expulsion tests and manometry, or the individual tests with defecography. And this is the resulting table, but I will only show these data, where the authors analyzed whether a normal or abnormal defecography will result, or how this is associated with both tests, the manometry and the balloon expulsion test being normal. And as you can see that with both tests being normal, balloon expulsion and manometry, the vast majority of patients also have a normal defecography. If one of the other tests is abnormal, around about 50% of patients will have an abnormal defecography. And if both are abnormal, 75% of patients will also have an abnormal defecography. They also again performed multivariable logistic regression analysis showing that only prolonged balloon expulsion test and reduced rectoanal gradient were associated with reduced evacuation and defecography. Again, from these data, because of these data, they recommend that when a defecatory disorder is suspected, both manometry and balloon expulsion test must be performed, and an abnormal rectoanal gradient and prolonged balloon expulsion test are the most useful non-defecography findings for predicting a defecatory disorder. Furthermore, they recommend that patients with one abnormality, either the gradient or the balloon expulsion test, should be diagnosed with probable defecatory disorder. They may also receive a defecography, but because both the balloon expulsion test and the gradient already have a high specificity for a pathological defecatory, this is not mandatory. Patients with two abnormalities should be diagnosed as definite defecatory disorder, and when the balloon expulsion test and rectoanal gradient findings agree, the additional investigation is probably not necessary. Okay, Serhat, you've appeared on the screen. I guess my time is up. I will briefly allude to the strengths and limitations of the study. The strengths are certainly that there is a really high number of healthy subjects and patients with constipation included, more than 6 subjects altogether, and they defined their own normal values, but it was a retrospective analysis. There were differences between healthy participants and patients, and not all patients received a defecography. And there was no clear reference standard, which is a problem because we actually do not know which of these investigations can predict the effect of the therapy, the effect of biofeedback therapy best in these patients. There was an accompanying editorial, which was written by Henriette Heinrich and Mark Fox. And it has the catchy title, One and Done. Is this gradient enough to diagnose defecatory disorders and guide the management of constipation? And Mark and Henriette agree that this gradient is really a good measure for rectoanal manometry. The data of the study validate current guidelines and can improve their acceptance. But they doubt that this parameter remains should be analyzed only. It cannot, as a single parameter, differentiate between functional and structural causes, and the visual analysis of recordings gives additional information. And with this, I thank you for your patience.
Thank you, Jutta. That was a lovely study. We have many beginners in the audience, and this is an open call, guys. This is a lovely topic. Young GIs, please work on this topic more. And, you know, I believe there are just people working in the whole world, even in this area. Could you please just briefly summarize again how to measure this rectoanal pressure gradient for the beginners, Jutta?
Mm-hmm. Yeah. This gradient can be measured using the systems and the analysis tools given by the different systems. So you can more or less get it automatically, but it is the difference between the rectal pressure and the pressure in the anal canal during simulated defecation.
Mm-hmm. Okay, Mark, do you have any question?
No, I just want to
if there is any question,
make a plea. I want to make a plea for just looking at your data. If you don't look at your data, you can easily run into problems because there are characteristic. Jutta is showing it to us right now. Sometimes pressure increases in the anal canal because of an interception, that is a small internal prolapse. Doesn't have to be visible from outside, that can come down and exert pressure on the catheter. And if you just look at the pressure during squeeze and during simulated defecation, if it looks exactly the same, then of course they're squeezing. If it looks completely different, as in this case, then you should really be thinking of doing the defecography. But what was really appealing from this huge data-driven study is that it basically validated the existing London classification. It's good to get a double check. If the manometry is abnormal and the balloon expulsion is delayed, then surely you have found something relevant.
Yeah. And it is certainly important to now check this by investigating patient or by giving biofeedback therapy to these patients and check whether a pathological gradient is enough to predict the effect of biofeedback therapy, which I also doubt. But it makes sense to have this investigation.
I have a question for both of you. A London protocol is fixed for both type of patients, incontinence or constipation. Do you think in the future, Mark, since you are running the Ascona initiative, there will be a different protocols for incontinence and constipation, or still we are supposed to run the same protocol for all patients?
Well, guidelines are there to guide. You don't have to stick to them slavishly. We want to be inclusive. We want to have people performing studies in the same way wherever this technology is applied. One very important reason why so little progress has been made in this field is because until the London classification, there wasn't a guideline that was universally respected and followed. But it's been cited more than 300 times since publication in 2019, and it seems to be catching on. You don't have to do everything all the time, but if you follow the guideline, then at least you're talking the same language, producing the same data, producing data that you can compare with other centers, other experts. That's what the real strength of this is.
Yeah. And said, even within this study of the Blackett study, one of the parameters which independently predicted a pathological balloon expulsion test was the increase in pressure during squeezing in patients who have a problem with we think, relaxation. So they probably not only have a problem with relaxation, but with coordination of their sphincter in general. So, and this is something you can only assess if you also test for it, and if you do not skip the squeezing part in constipated patients.
Yeah, that, and also the sensation, of course, because it goes in. They found associations with rectal sensation.
That's pretty important. Thank you, Jutta. That was again a lovely. There's a very interesting paper, though. Everybody should read the full text.
Lots of data.
Yeah,
read my editorial. It's much easier.
Yes, that's
true. And shorter. Yeah.
And shorter.
That's better. If you don't have time, just go ahead and read the editorial. Okay, Mark. Now we are going to look at your case report.
Yes, we're nearly there.
Functional outlet obstruction.
Yes, so I've allowed myself to change the subject slightly because it's a good thing that I did, because this one's nice and short. So a 53-year-old patient with a 2-year history of constipation, not responding to laxatives, a very common situation, I'm sure you'll all agree. This 53-year-old was complaining not only of constipation, but also of bloating, pain. She had intermittent hemorrhoidal bleeding as well. She'd been taking all kinds of different medications, but prokinetics tended to make her pain worse rather than better, and nothing really seemed to work. She also complained of upper abdominal dyspeptic and reflux-like complaints, which hadn't responded to PPIs. She was thin, she was unhappy. And on questioning, she didn't admit to this immediately, but when we asked to think about the possible causes, she said no, she hadn't been constipated since childhood, which is what you typically see in slow transit constipation. No, she had a perforated sigmoid diverticulitis in 2021, which had actually required quite a large operation to remove the inflammation and the section of bowel that was affected. But that was then, and right now, the laboratory tests, gastroscopy and colonoscopy all showed essentially normal findings. People had even done a magnetic resonance test to look for adhesions, and there was no such evidence. Here you see the sigmoidoscopy. The anal canal looked normal. The hemorrhoids aren't impressive at the moment. The sigmoid colon is of course missing, but the anastomosis between the descending and colon and rectum was wide open and not inflamed and not ulcerated. You can see a clip, but that's not unusual. Colon transit time was a bit more than 1 day, but it was a bit less than 2 days, and normal may be regarded, especially in women, up to 72 hours. The distribution was somewhat distal, which in the ancient literature suggests an outlet obstruction, so suggests a problem more lower down. And that does seem to be logical, but it's not really evidence-based. But there you have it. And then we performed anorectal manometry. And you can see here very quickly, the resting pressure was normal. The pressure increment was normal. The rectoanal pressure differential, however, was minus 46 millimeters of mercury, which is really quite high. That the rectal sensation was slightly hypersensitive, but not really impressively so. Here you can see the baseline measurements in resting pressure, slow wave activity. This is something that we see has been associated with all kinds of problems, but may indicate a certain kind of irritated state. You can see the squeeze pressure looks okay. And here you see a perfectly normal, healthy control. For comparison, it's not as impressive as this, but it's not abnormal. However, here, top right, you can see the squeeze. And now look at what's happening when we ask her to simulate defecation. Well, I put it to you that the pressure morphology, the sort of the pattern that you're seeing qualitatively, is extremely similar, whether she squeezes or whether she's trying to defecate. She is producing some pressure in the rectum, but this was less than 40 millimeters of mercury, which is considered to be the low normal. So here we have apparently a problem. And I want you to compare this to the simulated defecation here. Here you can see intraanal pressure massively elevated. You can see in the rectal, in the anal canal, that there's a gradient of pressure. You can see the gradient over here on this, the instantaneous pressure on the right side. And you can see that there's no obstruction. It's all going to be moving through here. And afterwards, interestingly, you see a relaxation. This is quite common. When people do this properly, they stop pressing, but the sphincter remains open for a second or two, just showing that there's no problem with relaxation itself. The rectoanal inhibition reflex was present. This is clearly not Hirschsprung's disease, but the patient failed to expulse the balloon. So she has a double positive, both of these things, both of them suggesting an outlet obstruction. And so this is indeed what the diagnosis was. She had post-operative IBS, very common after complicated inflammation, complicated surgery. She had abdominal pain following the operation, and we know from after operations, also after traumatic vaginal deliveries of children, this is a very typical event where the pain inhibits the normal defecatory process. The patient is tensed up and doesn't let go, and they don't notice that they're doing this. And that is essentially how they learn to do this wrongly. What do? We treat using a combination of stool regulation. You can use flax seeds, as I've said. You can use glycerin suppositories to stimulate evacuation. Not infrequently, if they get a nice urge to defecate and don't really do anything, then they can empty. It's when they really consciously try to push things out that things go really wrong. But most importantly, physiotherapy with biofeedback. Biofeedback is an idea where you're making these hidden processes obvious to the patient, and they show them what they're doing wrong, and they show them what they should be doing, and they work from one place to the other. Abdominal breathing to relax the abdominal wall, to breathe normally, is also very important. Part of the treatment, because almost all of these patients also have bloating and are very troubled by pain as well as distension associated to this tension in the abdominal wall, independent of what's going on inside their abdomen. This is a well-proven technique. The relative effectiveness depends on the control group, but in some of the larger studies, it's quite clear that if there's evidence of dyssinergia, then pelvic relaxation, breathing exercises, biofeedback are superior to simple continuation on laxatives and dietary treatment. It's also been shown by the same group in America, together with Giovanni Chiaroni, who's now back in Italy, that it doesn't work in people who have a clear evidence of a slow transit constipation. Jutta made me aware of a recent study from the excellent Barcelona group, now led by Fernando Aspiros, where they also did a prospective randomized control trial in 50 patients with functional dyspepsia, as well as functional constipation caused by dyssinergic defecation. And when they randomized these people to biofeedback or just continuing normal care, the biofeedback group didn't only go to the toilet much better than before, but their dyspeptic symptoms, their bloating, also disappeared. So this is a very important intervention. Physiotherapists are your friends, and you should train and encourage the physiotherapists in your area to provide this care. It's an extremely important part of my pharmacopoeia. You can also send people online. There's some excellent do-it-yourself training for defecation disorders and for abdominal bloating, provided by my friends in Mercy Hospital in Cork. They have lovely videos, they have lovely like animations that will help your patients understand what's going on and get better. So thank you very much for your attention, and I've got to show you this. This is what happens if everything goes really well. You see, that's what makes you happy. If you can go to the toilet, then everything is good. All right. So thank you very much for your attention, and I hope you have a lovely evening.
Thank you, Mark. There's a question from Dr. Albuquerque. He's asking whether linaclotide will help in a patient with IBS constipation.
No. Well, yes, maybe. I don't like linaclotide personally. I think it's like kill or cure. It either gives people diarrhea or it doesn't work at all. But I mean, clearly it does. It has been shown to be effective in IBS-C, but it's not effective in my experience in dyssinergia. All of these expensive modern laxatives, I like Resolor myself. If I have to choose one of them, this is a good medication in some situations, but it doesn't work in dyssinergia. It just gives people pain and cramps because they're fighting against it. So you need to recognize and treat this. If your pills are not working, the next thing is to think about dyssinergic defecation, because as Jutta has shown us, at least a third, maybe up to 50% of people with therapy-resistant constipation have this problem.
We use both linaclotide and Resolor also in combination in patients with very severe slow transit constipation, but they fail in patients with dyssinergic defecation, yes.
Maybe it makes sense to combine, as you said, and in order to give the patient enough confidence that they can expel the stool, because they come in with a crazy psychiatric situation saying that I cannot expel it. No way I can expel it. You know, in that way, it's good to make it a softened stool. Then,
oh yes, no, you do
breath exercise and everything.
You need to help your physiotherapist by softening the stool and using all of the tricks that you have with suppositories, as has been suggested, and everything else. They need to help. They need to get that feeling of success. And in truly therapy refractory cases, I also use Botox to weaken the sphincter, but only in patients that are engaged in physiotherapy, because Botox won't help. It'll simply, however, make it slightly easier for them to learn.
The question is saying that is abdominal breathing the same as diaphragmatic breathing?
Yes.
How do you instruct your patients?
Yes.
How do you instruct them? making
Not got enough time for that, Serhat. Go online, look up Mercy Hospital abdominal breathing or diaphragmatic breathing and learn.
Yeah, we have one in Turkish as well.
That's great.
I know, yeah, recorded by my nurse. Okay. Thank you, guys. We have just 61 minutes now. Okay, that was a lovely meeting. Thanks, Mark and Jutta, for these lovely presentations. Can we look at the next? Could you please turn off your sharing, Mark? Then we can show the next one.
Yeah.
Please join us for next 3 meetings. They are already scheduled in this situation. Next one is coming, next one is coming on 3rd of April regarding the bile acid diarrhea. And the other one is coming 2nd of May, microbiota and functional bowel disorders. And the last one is coming 5th of June, postprandial distress syndrome and functional dyspepsia. This was a webinar organized by European Society of Neurogastroenterology and Motility and Turkish Society of Gastroenterology. Thanks to the speakers and thanks to the people behind the curtains helping us, Burcu and Sinem, and see you in the next meeting. Bye-bye. And
thank you, everyone.
Bye. Thanks.
Bye-bye.